About joint replacement, amputations, osteoporosis, osteoarthritis, and fractures, all things musculoskeletal. So the first thing I'm going to talk about is arthroplasty. And with that, it really means a replacement of a joint, okay? Don't confuse that with arthroscopy, which is like the providers or the orthopedic surgeon, I should say, is going to take a scope and look inside the joint and probably take some fluid out and test it. And so, for example, that would be used to look for rheumatoid arthritis or osteoarthritis. But we're going to talk primarily here about total joint replacement, so an arthroplasty. It means removal of the joint. So they essentially throw the old joint away and they replace it with a prosthetic. And this it can be done in a lot of joints. All right, but we're primarily going to talk about total hip and total knee replacements. The client presentation, these are symptoms of osteoarthritis. They have pain when bearing weight, joint swelling, crepitus, and limited joint motion. Contraindication, so pre-op you would figure this out, right? Recent infection, any arterial impairment, so decreased blood flow, inability to follow the post-op plan, and comorbid conditions. Pre-op testing, you know about. Pre-op teaching, they may want to donate their own blood or they may need epoetin. Joint surgery is very bloody. They often drop their hematocrit and hemoglobin after surgery. You know they need a surgical scrub, clean linens the night before, wear clean pajamas, and they need to take hypertension meds, especially a beta blocker with a sip of water before the surgery. This is to prevent an intraoperative MI. So that's very important. Avoid herbal supplements before surgery. All the G's, so garlic, ginger, ginkgo, ginseng, grapefruit, these all could cause bleeding. That's why you have them avoid them. Post-op teaching, post-procedure, they're going to need extensive PT. They go home pretty quick or they go to rehab. DVT prophylaxis is a must. So they are at high risk, the highest risk with the total hip replacement actually, but knee replacement is also high risk. So you want to get them working on their leg exercises, both feet in the other non-operative leg. So you want them moving dorsiflex and flexing the feet back and forth, okay, to prevent a DVT because we don't want any circulatory problems. You want to encourage the incentive spirometer and encourage turn, cough, deep breathe every hour while awake. And don't forget your frequencies because you got that wrong in the last exam. Surgical drains, they will. I'm going to show you pictures of those and assess for an infection. Usually hips have this drum, accordion, hemovac to drain the fluid, and knees usually have this striker drain, which can auto-transfuse this blood within 6 hours. Ice therapy to reduce swelling. So my patients, my knees came out with this already attached to it to reduce the swelling. So total knee replacement, you're going to have to do, okay, so anybody that has any kind of musculoskeletal problem, like they have a cast or they have a total joint or they've had a fracture or trauma, you're going to do the 6 Ps. You immediately post-op, it's 1 hour, Q 1 hour for the next 24 hours, and then it's Q 2 to 4 with vital signs, okay? You want to avoid positions of flexion with the knee arthroplasty. Remember the pre-op antibiotic 1 hour before the incision, then 24 hours post-op. Keep heels off the bed and monitor for shock-like vital signs to make sure the patient's not bleeding. So that's tachycardia, tachypnea, hypotension, and narrow pulse pressure. Okay, continuous passive motion machine. This is to maintain mobility, and it's set to a certain degree, and it goes to full extension, okay? You never want to give the remote to the patient if they are confused. If they're not confused, it's okay. They can never do deep knee bends, or they cannot kneel in the future. With a total hip replacement, same thing. They're going to need the 6Ps Q1, every Q1 times 24 hours, and then Q2 to 4 with vital signs. All right, so I already talked about the shock-like vital signs, and you got to know if they are allowed weight bearing on that side. Transfer out of bed from the unaffected side. They can also sit in a wheelchair upright or with a back that reclines, okay? They can't sit in low chairs, though, because they can't let their hip go beyond 90 degrees. After somebody has a hip replacement, it's quite painful. We used to use nerve blocks when I worked in the PACU, and that really changed my life because patients didn't feel any pain. They get PCAs typically. They use multimodal pain medication. No meperidine, because that makes them confused and it can cause seizures, which the other name for that is Demerol. Other opioids, you want to make sure you're watching them and monitoring them for acute confusion. Okay. For precautions, total hip precautions, avoid flare. Flexion beyond 90 degrees, adduction, that means bringing the legs together, and internal rotation. Okay, so you want to always maintain abduction with a wedge pillow or just regular pillows between the client's legs. You maintain neutral rotation. They need raised toilet seats. They need to use assistive devices because they can't bend their hip beyond 90 degrees. They can sleep on either their back or their non-operative sides with pillows between their legs, but they can't like sleep in the fetal position. Keep the legs straight if they're on their side. They can externally a little bit rotate their toes. Tell them not to cross their legs and avoid turning to the operative side. So for DVT prophylaxis, they could be on heparin SC. Most people are on enoxaparin. With heparin SC subcutaneously, you have to check the hemoglobin and platelets. With warfarin, check the PT to make sure it's therapeutic. At the level would be 2 to 3. Everywhere I've ever worked, you check the PT at 1700, and if it is not above the 3 or whatever, then you give the warfarin. Okay. SCDs take off Q8 and encourage foot pumps Q1 hour while awake. Complications include dislocation. That's why you follow the hip precautions. Also DVT, so look for that red, painful, swollen calf with edema. Sudden shortness of breath, pleuritic chest pain for a PE because they're high risk for that. We talked about bleeding, neurovascular compromise, and then get a Doppler if you can't find a pulse. Now I'm going to go into amputations. Okay, we didn't do an activity about amputation, so I'm going to go in a little more depth here. Okay, so an amputation is obviously removal of a body part. And the higher the amputation is, like the higher on the leg, the more effort it's going to take the patient with the prosthetics, okay? They can have an above the knee amputation or below the knee amputation. So the above the knee amputation is going to take more effort after they get fitted for the prosthetics and start trying to walk. The level of the amputation is determined by the blood flow. So the provider or the vascular surgeon would determine where the amputation is going to be based on the blood flow. So they may have an arteriogram. All right, health promotion. We talked about this for the last exam. This is most likely going to be people that have peripheral arterial disease. So they need tight glycemic control, which means keeping their blood sugar in the proper range. They need foot care. They should never walk barefoot. They should quit smoking. They should exercise, maintain a healthy weight, and safety precautions with machinery because they may have neuropathy. Risk factors, PAD, we talked about that, trauma, osteomyelitis. All right, recognizing cues, alterations in the 6Ps. So they may have pain, You get a Doppler to help find the pulses if you need it. Okay, now pain is not going to be the most important one in the 6Ps. So look for the other signs too, like if they don't have pulses, look for paresthesias or sensations that are diminished. Cool to touch, pale cyanotic or gangrenous, and lack of sensation. Diagnostic testing, an angiogram to determine impaired circulation, Doppler studies, and an ankle brachial index. All right, traumatic amputation. If you have somebody, there was just a story on the Pit this week about somebody that had their leg amputated. It was beautiful. They did a really good job with it, with the tourniquet on the leg. All right, so you're going to activate EMS. Somebody comes to your house, they know you're a nurse, and they amputated a couple fingers with firecrackers or something. Activate EMS. Hold pressure if bleeding. We're going to stop that first, right? Elevate the extremity above the heart. Wrap the extremity in sterile gauze or a clean cloth or a towel, something clean. Place it in a Ziploc bag. Then place the Ziploc bag with the digits into a bag that is ice water, okay, mostly ice, and send it to the ED with the bag and label it. Do not put the extremity directly on ice or in the ice water. You have to put it in the plastic bag first. Nursing care after amputation, frequent vital signs. You're going to be checking the 6Ps, and this, I should say, in the stump, and monitor for pain and phantom pain. Okay. Palpate the residual limb for temperature. And I'm sorry, if I call it a stump, that's what we always called it. But now the new name is residual limb. Phantom pain, it's a real pain that they feel, and it's in the location of the removed extremity. Can occur anytime. Could be more neurological in the way it presents. Okay, so they treat it with like calcitonin, beta blockers, or gabapentin. Baclofen is another drug they might use. In terms of the residual care limb, you want to they try to shrink it, so decrease the edema. I'm going to show you how they do that in a minute. They need to engage in limb strengthening exercises and manage pain. Okay, you want to reapply. You're going to put a figure of 8 dressing on the patient's residual limb to reduce the swelling so that they can be fitted for a prosthesis. Okay, so another way to talk about the bandaging is it should be applied distal to proximal direction to prevent ischemia. Okay, this is called a figure of 8 dressing. They would put that on to try to shrink the residual limb. Okay, this is a tourniquet. Okay, after the procedure, after somebody has an amputation, they're going to be high risk for bleeding. So if they start to have an arterial bleed, you're going to have to put a tourniquet on them ASAP and stop that bleeding. That's the first thing you're going to do. All right. Now, say the patient comes back to you from the PACU or they go to the floor. Most surgeons do not allow elevation of the residual limb after 24 hours, and that is to prevent flexion contractures of the hip and knee. All right, so if your patient still has a little edema after the 24 hours, don't put the limb on a pillow. Raise the foot of the bed if they have edema still, okay? They need to go prone 20 to 30 minutes every 3 to 4 hours to prevent hip flexion. They should not sit for long periods of time because that's going to cause hip flexion. And they need to stand with the residual limb extended. And so when they're lying in the bed, they can kind of press on the residual limb. Yeah, so that's amputations. And remember, if they're going home, they're going to have to, figure out a new way of living. So take care of their psychosocial needs. All right, osteoporosis. We went over this in class, so it's kind of pretty straightforward. Okay, osteoporosis is a metabolic bone disorder. Osteopenia comes first usually, um, and that means like more softening of the bone, whereas osteoporosis is more spongy. So health promotion and prevention, we should all be getting the right amount of calcium and vitamin D. We need sunlight. We can still wear sunscreen. Quit tobacco, limit alcohol, and engage in weight-bearing exercises. So like swimming wouldn't count. I love swimming, but it doesn't count to prevent osteoporosis. So I run instead. Vitamin D foods, you got to eat them, got to know what they are. Calcium. Powdered milk has calcium and protein. I remember when I was in home ec, that was a big deal. That was a good calcium source that we needed to know how to make. It doesn't taste real good. All right, risk factors include Asian and white women, especially if they're skinny, over 50 and postmenopausal, history of low calcium in the diet, or if they're on a high protein diet. So we don't really tell you this in nursing school, so I'm going to make it short. Calcium in the bloodstream is bound to protein. And also, if they eat too much protein, it's going to cause them to put out calcium in their urine, okay? So they're going to lose calcium in their urine if they're on a high protein diet. If they have low vitamin D, so they don't get outside or eat vitamin D foods, they're going to be at risk. More than 3 alcoholic drinks a day or chronic alcoholism is going to put them at risk. 3 cups of caffeine or 4 sodas puts people at risk for osteoporosis, okay? Because when you're urinating, you're leaking out all that caffeine. Malabsorption disorders like a gastric bypass, but like after 6 months of having one. Eating disorders. People that had eating disorders in their teens are at risk for osteoporosis when they get older. All right, so recognizing cues. They're going to have reduced height, history of fractures. This is kyphosis right here. Okay, so they kind of look humped over. They'll have back pain that gets better with rest. Height loss. I've lost a couple inches since high school. They'll have stoop posture. They could complain of bone and joint pain. Okay, diagnostic testing. Check the calcium. Calcium is going to be low if the albumin is low, and it could be high if the albumin is high, because most calcium binds with protein in the bloodstream. Okay, phosphorus and calcium are in an inverse relationship. And alkaline phosphatase is high. It is indicative of cancer of the bone if it's high, and also biliary obstruction if it's high. It could be. Diagnostic testing. DEXA scan is test for osteoporosis. And I've had one done. It's really easy. You can wear your clothes, but you have to remove all metal from the body. It's not for pregnant women or lactating women. And you lay down on this table, and it's over before you know it. They just x-ray your whole body, your spine and your long bones. Client teaching, calcium and vitamin D, very important. Sun exposure, weight-bearing exercises, 30 minutes 3 to 5 times a week. And use all those safety measures you know to prevent falls. There are medications that you can use to prevent it. Hormone replacement therapy is good, but there's high risk of DVT and stroke with that. All right, calcium and vitamin D supplements, very important. Biphosphonates, take with 8 ounces of water, remain upright for 30 minutes. There's a risk of esophagitis with it, okay? Therapeutic procedures, they could have a kyphoplasty or have to wear some type of brace. Okay, osteoarthritis. We had rheumatoid arthritis earlier in the semester. Osteoarthritis is a non-inflammatory type of degenerate joint disorder. So usually the risk factors are age, joint injury or repetitive like sports injuries, and obesity. It's not inflammatory, so they're not going to have a fever. They may be stiff when they wake up, but they should get up and get moving, okay? You don't want anybody on bed rest, right? Pain improves at rest, and usually it's the knee and the hip that are affected. This is somebody's hand who has rheumatoid arthritis. Okay, we went over this earlier. The joints become spongy, and they have ulnar deviation, meaning it deviates from the ulnar side of the wrist. And this is osteo. See how they look different? You don't need to know the names of these nodules, but I was just showing them to you. Okay, now fractures. Okay, fractures. Fractures are usually due to trauma. Sometimes it's a disease process, like if somebody had cancer, they might get pathological fractures. So they may also have soft tissue injuries when they have trauma. And this is important because if you have a soft tissue injury, you have to be able to recognize this. You're going to have increased potassium, creatine kinase, and AST, aspartame aminotransferase. Those three, well, there's two enzymes in potassium, live inside the cell, so they're intracellular. When you have a crushing injury, these are going to leak out of the cell. And why that's important for you to know, because they'll test for this, is that a lot of CK or CPK is the other name for it. It can clog up the kidneys and cause kidney injury. And you'll learn about that more in med-surg too, but you need to recognize it now. So I made a mnemonic, AST equals CK. So a soft tissue injury equals crispy kidneys, okay? So you need to be able to recognize that. Lots of different types of fractures. Somebody with an open fracture is going to be more prone to osteomyelitis, okay? Health promotion, do all the safety things you're supposed to do. Okay, somebody that has a fractured bone, okay? They're going to have pain and tenderness. They could have deformity. Never try to put it back together. Bruising, crepitation, which is that grating noise. Loss of function, muscle spasms, edema, and subcutaneous emphysema. All right, diagnostic testing, they'll do an x-ray usually. They may, if it's a pelvic fracture or hip fracture, they may do a CT. Emergency care, I talked about splinting as it lies. Fractures need neurovascular checks, Q1 hour times 24 hours. So you're going to have to prepare for a mobilization of surgery if it's emergency care and it was trauma, okay? Assess the 6 Ps, Q1 hour. Okay, so remember they're going to have pain, so that's not going to be your priority like P, right? So you're going to check for pulses and cap refill. Poikilothermia, which means you're going to take the dorsal side of your hand and feel the skin temperature, and you want to make sure it's warm. Paralysis, you're going to check for movement. And paresthesias, you're going to check for sensation, numbness and tingling, ask them if they have that. And pallor is for the color of the skin over the fracture. If they're immobile due to their fractures, you know what to do with fluid intake, fiber. Give them vitamin C to acidify the urine so they don't get kidney stones. All right, medications. Again, opioids and NSAIDs. With older adults, be very careful with opioids because they could get confused. Muscle relaxants are used. Stool softeners are good for everyone that is laid up. And antibiotics, especially if it's an open fracture. Lots of different ways they can try to fix a fracture. We talked about that in class. When they do a cast, the teaching you're going to do is tell them never to put anything down the cast. If they're itchy, they can get a blow dryer and put, set it on cool and put it over their cast or down their cast. Okay? They can put a plastic bag over the cast for a shower Never take a bath with a plastic bag if it's a plaster of Paris cast. All right, trapeze bar, definitely want that because it promotes independence. If you're going to use ice on a new cast, okay, you need to put the ice bags against the cast, not on top of the cast. And you won't even touch the cast if it's a plaster of Paris and still drying. Once the cast comes off, it may need to be replaced. Because the edema is going to subside in a few days, so they may need a new cast. Again, for a cast, neurovascular checks Q1 times 24, ice times 24 to 48. Make sure you're holding the cast with the palm of your hands, and you need to be able to fit one finger in between the cast and the skin. All right, traction. Traction is not used that much anymore. You have to know the difference between skin and skeletal. So skin means there's bandage applied to the skin, and it has 7 to 10 pounds of weight. Bucks traction is an example. And the reason they would use this on somebody with that fractured their hip is to decrease muscle spasms. Skeletal traction has pins, wires, tongs directly into the bone, and it's more than 10 pounds of weight. So people with skeletal traction are going to be more at risk for osteomyelitis than people with skin traction. When it comes to traction, you never remove those weights. You keep the patient in the center of the bed, keep the body parts in traction in a straight line with the trunk. Make sure the weights, see these weights, they need to hang free, not resting on a table. They need to hang free. You can pull the patient up in the bed without lifting the weights. Don't let their feet touch the footboard, like if there was a footboard here, because that just defeats the purpose of it, okay? And then make sure you're checking the skin and ensure the ropes and slings are not pressing into the skin, and make sure they're not knotted up. An external fixator, never use the fixator to remove the leg. You're going to have to do pin care just like you would with skeletal traction, and 1 cotton swab per pin, and you use whatever solution is approved. It's either normal saline, sterile water, or it could be chlorhexidine. Osteomyelitis, you need to know how to recognize this quickly. Okay, it's a bone infection, and they'll have sudden onset of severe pain and tenderness, a high fever, headache and malaise, swelling at the site, high WBC and ESR. Antibiotics are going to be prescribed for 6 weeks, so they're going to need a PICC line most likely. All right, now if the affected limb is immobilized, will be immobilized for complete rest. All right, sometimes if they can't treat this, it persists, they may have to have the limb amputated. Fat embolism, you got to know how to recognize this definitely, okay? This happens to people who have long bones that are fractured, like a femur, pelvis, or ribs. You'll see a change in mental status first, tachycardia, tachypnea. They'll have respiratory distress, crackles and wheezing, rapid pulse and fever. Stay with your patient, place them in high fallers, put on oxygen, and make sure you have a line, peripheral line. Now, the last thing is petechiae, but it's usually like the last assessment finding. You're going to see them have a change in mental status and be tachypnic and dyspneic before this. A measles-like rash over the chest, neck, upper arms, and abdomen. So this petechial rash differentiates like a pulmonary embolism from a fat embolism, okay? It's specific to fat embolism syndrome, all right? Compartment syndrome, okay, it could be very damaging. It's a medical emergency, and it results in severe unrelenting pain, even if they've had narcotics. That's like the cardinal sign. They'll have compromised 6Ps, and they need immediate surgery, so do not elevate the limb. Oftentimes, we elevate the limb to prevent compartment syndrome, but then once your patient gets it, do not elevate anymore. Take it off of elevation, the limb. I want my best nurse taking care of this patient, because if she discovers compartment syndrome, there's going to be a lot of work that needs to be done, and they got to get to the OR quickly. Okay, there you go. There's your musculoskeletal recap.